Yes, Manish, I'm here at Kokilaben Ambani Hospital Cath Lab,
Yes.
and we are a big team of interventional radiologists. I have Diptiman to my left and Gordon right in front of me, and my technical staff, Dr. Rahul, and we have our nursing staff here. What I will do now, I'll ask my colleague, Dr. Hassan Kabito. He is from Uganda, and he's here for training with us. He will be presenting the case just now.
Wonderful. We're looking forward to it.
So I will, yes. So let us work with that and see what happens. What is the case like? Stiff fire de dono.
Okay, we see
So,
the demographics. Go
Hassan?
ahead.
Yes, yeah, there it is. Let him talk to you.
Yes, go ahead and proceed with presenting the case.
Yes, Hassan, go ahead, please. Sister talker.
Okay, Vimal, we see the non-healing ulcer. He's a 77-year-old male with renal insufficiency and diabetes, which is very common in our practice. Go ahead and give us the other details.
Okay, so did you hear Hassan? Hassan, did you give it? Oh.
No mic there.
Okay, there's no mic there. Okay. As you can see, this was a elderly diabetic male with a non-healing ulcer over the heel.
Yes.
In the right side. And we will just show you the images now. Put up the images. Yes. So you can see that the bifurcation of the aorta there.
Yes, we see it.
With a, just minor stenosis at the ostium of the right common iliac artery.
Yes.
We confirmed that that was insignificant. We did a pressure gradient there.
Okay.
And we did not get any real pressure difference between the two sites. Then we came down into the SFA. No, it's... नहीं हो रहा है?
We do see that, yes.
सपोर्ट वहाँ चाहिए
तो देख लेंगे फिर उसको बाद में खोलेंगे उसके बाद में
ये कर देते
हेलो कनेक्शन गया है
प्रोग्रेस निकाल देते हैं इसमें भी एक्सटेंशन लगा के रखें
We hear you, Vimal.
अरे बाप रे उधर नहीं है एक्सटेंशन
मार नहीं होगा
लूप अपना नहीं जा रहा प्रोग्रेड का
नहीं बट प्रोग्रेस बढ़ेगा नहीं बढ़े प्रोग्रेस भी नहीं बढ़ रहा है ना नहीं तो इतना प्रोग्रेस बढ़ता था ना स्ट्रेट हो जाता अभी सब हेड एंटर भी नहीं है ना
Vimal, do you hear us?
सिस्टर टॉर्क कर देना
Can we go to the live image, please?
You have the live image with you, Manish?
We are not seeing the live image.
Oh, okay. Let them get the connection on.
Okay, we see the runoff. Yeah, now we see the live image. We see you.
Okay, can we just see the SFA? SFA was more or less normal.
Yeah.
Can we see the SFA popliteal junction, please?
So, Vimal, just as a descriptor for our audience, not all of us are peripheral experts like you. What is your target and what are you aiming to revascularize for his critical limb and non-healing ulcer?
Yes. Okay, so I think unko just show this picture, Rahul. I'll just show you the popliteal artery and the trifurcation there.
Yes,
Okay, so the SFA looks normal.
yes,
Some plaque in the distal SFA, not significant though.
right,
When we come down at the popliteal, and if you can see the distal popliteal, there is about 70% plaque.
yes,
And the ATA is showing a lot of disease. And as you go down, there is more or less a tight occlusion in the proximal ATA.
correct. We see that.
And the mid and distal again shows a significant amount of stenosis.
Yes, we see that very well.
And coming to the so-called tibioperoneal trunk, there is a tight stenosis at the ostium with a long segment proximal stenosis and occlusion.
Okay. And
Now our target as of now is to open up the tibioperoneal trunk, which runs down as a posterior tibial.
okay,
This is a normal variation which is there. The peroneal forms the posterior tibial distally.
yes,
Okay, so this is what the scenario is. And so now I will take you through what we have done today.
okay, very good. We see that.
Our aim is to open up the tibioperoneal trunk, which forms the posterior tibial distally. And I will also put a stent in the distal popliteal.
Okay,
ATA, we will try and cross it if I can get it. I'm going to do that. To see that, I will revascularize the whole foot.
yes. So now what
now I will
equipment,
take
what
you through
equipment
what
do you
we've
have
done.
in?
Sorry.
What equipment is inside?
Yes. So I will start showing you what we've done today so far, so that I do not waste your time. Can we go through the first the sync pictures? Okay. So what we've done is we've taken a left femoral puncture,
Yeah,
and this is a step that we are trying to show you for a crossover. We've got a RDC catheter,
mm-hmm,
which we turned it around and got it into the SFA.
okay,
I supported it with a Amplatz wire, a super stiff Amplatz wire. And with that, over the super stiff Amplatz wire, which is this yesterday's you are showing. We are continuing with the yesterday. Just show this foot one, just the foot one. Just to show you how the peroneal is forming the posterior tibial in the leg. There it is. You can
Yes,
see that it
yes.
is turning sharply
yes,
just above the ankle and forming the posterior, and looks very good. So if I can open that segment, the heel would heal off. That is what my plan is.
correct. Okay, so we got it. Yep,
Okay, so we go for the images today. Okay. Yes. Here I'm just pushing the terumo wire to get it across onto the opposite iliac artery.
yeah,
And now I will take my RDC catheter down into the SFA.
yes,
And I exchanged the terumo for a Amplatz wire now.
yes,
Next. And over this Amplatz wire, I'm getting a 7 French crossover sheath. I've taken a 7 French primarily because I want to put 2 wires parallel to each other
correct.
into both the tibial arteries.
Right,
So here is the 7 French crossover Cook sheath. I've got it down into
Okay.
the common femoral artery. Now I'm getting my head under catheter, which is my support catheter, down into the popliteal artery. Next. And I will bring it down at the level of the trifurcation, because that will be a good support. And I take a head under because it gives me a little angulation.
right, okay, I see that.
I can go posteriorly, I can go anteriorly to ATA, PTA. And this is the reason I use this. Next. We are down at the level where there is a disease here, as you can see that. And over the road map now,
Yes.
I normally use a micro catheter. We use a pro-grade catheter.
Okay.
This has a soft curve and it can be used as a flexible wire as well as a stiff wire. I'll show you how it goes. Now you can see that the wire is tending to go towards the anterior tibial.
Yes.
There's a resistance there, so I'm forwarding my diagnostic catheter to give me a little support. Next. And there finally I could get my prograde. You can see the soft loop of the prograde
Yeah.
tracking through the stenotic and occlusion segment. I'm trying to now get my prograde catheter, which is 2.2 at the tip.
Very nice. I see. We see that.
So with that, yes. So there is a loop which is helping me go forward, and there you can see I'm just tending to go there. Next.
Very common to our coronary
Now
techniques.
you will see a little. Yes. So now I've got it at the level where there is a CTO.
Yeah.
And what is interesting is where there is a occlusion, there are two branches, just collateral branches.
Yes.
So the soft terumo wire was tending to get into that continuously. You can see that.
Right.
So I had to change the strategy now to get in a CTO wire, and I have taken a Conquest Pro.
Okay. For
Now you
penetration.
can see that Conquest
Good.
Pro is more or less trying to run down, yeah.
Yeah.
And I'm trying to rotate and push, maybe subintimal some extent. It stopped here. Next. Then with the torquer, I could continue to torque to get the wire further in.
Okay.
And at a point, I did break in. So I'll just show you those steps also. Next. I think in all this procedure, getting a wire across is, now you can see that my wire has gone down.
Yes, I see that.
So it was getting stuck at the upper end, and there was a long segment stenosis and occlusion.
Right. Your proximal cap was rough. Yes.
Go back, go back. Yeah, the proximal cap was a tough one. So these CTO wires do help us to cut through that. And I confirm my wire position on the angiography down there.
Right.
And then once that was there, I connected it to this Conquest Pro is a 180 centimeter. It's not an exchange length. So I had to come back, pull out the prograde catheter as well as the diagnostic 5 French catheter which was supporting it. All that was pulled out over extension wire. And
Right.
here is the extension which I have connected here with this. Keeping that wire in place, now we started attacking the anterior tibial artery.
Yes. Okay. Got it.
And you can see that ATA has a lot of problems there. So by the side of the previously placed wire into the PTA, I got a 5 French head enter catheter with a Terumo wire to get into the ATA.
Okay.
There you can see that the ATA, it is tracking in. This segment is going smoothly. And I got my prograde catheter over it, and then tracked my 5 French catheter to support me at the ATA ostium.
Yes, we see that. Okay.
So there I am. At the distal end, you can see that now my wire is tending to go somewhere. If you can see, there is more or less multiple small collaterals coming up. Probably
Yeah.
the straight line is the actual vessel.
Right. You've got a lot of collaterals.
That's right. So it tends to go into the collateral. So I'm going to kind of torque my wire and get into the ATA ostium. ATA wherever there is a continuation there.
Yeah, it looks like a CTO itself again, short
So the-
segment.
Yes. So I'm going to struggle, and finally I did get it across. I hope I can show you that. Maybe it's the next one, Rahul. There we are. So you can see my diagnostic catheter, you can see the prograde, the other wire in the PTA. What are we doing now? Next. Okay. Now I've got a wire. There it went down, as you can see that.
Yes.
And as I come down, I more or less negotiated most of the ATA stenosis except for the distal one, where we are stuck at the present moment.
Okay, thank you for getting us up
I'm
to
not
date.
in a position to advance my wire,
Right,
neither my prograde catheter. So I'm going to make a little effort there because that's not my target vessel to open. My target is the PTA and the popliteal artery.
very well, okay.
So if I could show you something over there as far as my technique to get it across the CTO on the ATA, I'm going to do that.
That would be wonderful. Okay, thank
So
you.
this is a, okay. So we have a Fielder FC now on this. Is it the Fielder FC? Conquest, yeah. We have the Conquest again because I was hitting at the stenosis
It's a
in the
headhunter.
ATA, mid ATA.
Yeah, the headhunter.
Yeah, that's a headhunter which I had used, yes. And what happened was I then dilated the proximal segment with a balloon to help me push my prograde catheter down.
Right, okay.
And now I'm going to try to handle the distal end of the ATA and see if I can get my stiff wire across. Can I just see that? Yes. So I'm working around, you can see my prograde catheter down there,
Yep,
and I push my stiff wire there. And here it is now, there's a CTO there. And even the stiff wire is tending to go into the collateral branch. There it is probably where I'm hitting. And I think it is turning still into the collateral branch there. I've turned it little and trying to poke a little away. I think I've got a little access there.
yeah.
Manish, I hope you can appreciate that.
We
Now
did
my
see
wire
that.
is tending to go.
Absolutely, yep.
Yes. So I've got that calcium which is guiding me. I'm still again stuck there. My problem is I cannot get, I got it through again.
There you go.
So that's a good, Rahul, record that please.
Very nice.
So it is a CTO wire which is getting me passage down there. And I'm not going to go too far down on this. You can see my wire now going smoothly into the ATA.
Yes.
Any questions amongst the audience, please?
Dr. Al-Samri?
I thought there was
You can see that it is going down smoothly in my branch.
Yes.
So I may be in the dorsalis pedis down there, yeah?
Yeah, there's one question from our panel, Dr. Al-Shamri.
there is a microcatheter
Yes.
inside the glide. So do you use it now again, or you remove the
So
microcatheter?
when I'm putting my yeah, I usually have a guide catheter on top to support it. You know, the head enter catheter forms a good course in the ostium of the ATA.
Okay.
If you don't have that, then the wire has a tendency to flip back into the popliteal or back into the adjacent collateral or branches.
Right. Now, I
So
know
as
you're,
you can see, I'm pulling out my, yeah.
I know you're working here, and we've gotten access to both the AT and the POP. My question is when do you go pedal access, Vimal? And how often do you need to go
Sorry?
retrograde pedal access?
Okay. So if at this stage, if I would have not got an access with the stiff wire and all,
Yes.
then I would have got a retrograde puncture.
Yes. Okay.
So it's as of my practice, I think maybe about 5 or 7% of the time that I need a retrograde access. Sister, we'll need the balloon now.
So what
So
will your
what I'm gonna
strategy
do
be
now
now,
is-
Vimal? How are you going to treat these the popliteal and branch vessels? Are you going to debulk? Are you going to DCB? Are you going to balloon and stent? What's your algorithm?
So, yeah, okay. So I'm going to do my balloon dilatation with a tapered balloon.
Okay.
So I have the I have the Invatec balloon just now with me, Amphiron Deep, which is 2.5 at the distal end, and proximal is 3 millimeters. And this is 210 centimeter long balloon.
Okay. So tapered 210
Another
centimeter.
challenge
Wow.
that I have.
Okay.
Yeah, so this is a long segment disease that I have.
All right.
And as you can see that my challenge would be to track this balloon
Yes, all the way
through
down.
the occluded segment where, yeah. Though I have dilated it proximally, the other problem that I have here is I do not have any support for the balloon and the wire in the ATA, because now I don't have a guiding sheath. In fact, you have this Cook Ansel sheath,
Yeah.
which has a slight curve, and you can take it down 90 centimeter or 110 centimeter that you get. So you can come from crossover and place it into the popliteal and the anterior tibial or posterior tibial and get a good support there. Sorry, my wire is just going in.
Yeah, we see that. Yes.
When do you
This
use
is
the
the-
antigrade
oh God, I've got
axis?
a problem. Sorry?
Antigrade axis?
देखो अभी
Do you do
problem
it?
हो गया. This has come up. Now my problem is, you know what, Manish?
Yes.
My junction, that connection between the extension and this has slipped off.
Okay, we'll
So my
take it.
anterior tibial axis, okay, just show upper. What is happening? Oh, I won't be able to salvage this now. So this is one problem with the extension wire that we have.
Yeah, it often slips off. It's the same in the coronaries.
Yeah, because of these long segment balloons, we tend to get that. नहीं जाएगा. I'm just going to try this. Let me see if I can exchange my. Wait a minute. No, the wire is also coming out as I'm pulling my wire balloon out. So I'm not going to get that access now. So what I'm going to do, I will not take your time. I will complete this, but I will take another balloon and come on to the other one. That is the posterior tibial, which is my target artery.
Okay.
And once I finish off with here, I will again come back to you, just show you the last part of it.
And these are the real world problems that we all face in the lab that happen every day, the things that we need to do. There are limitations
Yes.
in equipment, limitations in what we have on the shelf, and limitations in what will
Yes.
cross and what we need to then get down to do the job with dilatation. This is why, at least Vimal, in the United
Yes.
States, the number of retrograde cases has started to climb because you subvert some of these issues if you have a good opportunity and
Yes.
a technologist to stick in the foot and then go retrograde.
So the problem with this
Oh,
case is the,
Yes. It sounds very
use of
logical though, yes.
Yes.
All this is avoidable then.
very distal occlusion of the anterior tibial artery. So retrograde if it is more proximal anterior
Yes.
tibial artery occlusion.
Right. So we will take this balloon again to come on to the posterior tibial. We got to just see that my junction does not come off here also.
I noticed duct extension
So we have-
works in Asahi and Abbott, but extension works only on Asahi,
That's correct.
and it has a bigger.
Right.
So it's good to introduce it, but to take it out, but not to introduce it.
That's right. And it comes apart very easily.
Yeah.
Right.
So we're talking about
So,
extending a short
um,
wire into a longer wire. There's a called a dock extension that connects like a Lego piece, one wire into the other to extend it. And it connects, and when you're pushing balloon in, it's okay, but when you're pulling balloons out, it tends to separate. And that,
Yeah, that's a big challenge there, yes.
So
why
yeah,
not? Yeah.
but you need to get something to exchange it. So once you get in, do you exchange?
Yeah, we need little more. Yes.
You don't
So
have
I'm
that.
now getting onto the posterior tibial segment,
Okay. We'll answer that.
and there you can see my balloon is going down. It often becomes really tough to get it down. So
So
here
this-
I'm getting a little resistance there. The joint has come out. So you can give me little support there so I can push it little harder. Yes. With little of support with the wire and then little push, I can track, I'm tracking my balloon there. I think I should be down there within the vessel, yeah. So I'm quite okay with that.
Yeah.
This is more or less the normal segment. I'll reconfirm it. Give me the contrast, sister.
Now he can exchange. Once you got the balloon distally, he can exchange
Little more.
it with
Ah,
the
tick,
300
tick, tick, little
centimeter
there.
BMW or something. And this is cost.
Okay, so here it is. I think in these kind of cases, DSA is an absolute must.
Absolutely. Yeah. You cannot do this without DSA.
Yeah. Yes. So there we are. My balloon is down there, probably in the distal posterior tibial here, quite a bit. So I'm gonna just withdraw a little and try ballooning it at 2 levels, and that should be good for me. Okay,
What's the name of that balloon?
connect.
Vimal, which balloon are you using
Yes.
here?
This is also Invatec, right? Amphiron? Nanocross. This is Nanocross from
EV3.
EV3.
And this is what size balloon?
This is 2.5 150.
Very nice. Thank you.
So here you can see that I think those are bubbles in the balloon probably. And these kind of long segment disease, we normally keep it open. The balloon is inflated for at least 2 to 3 minutes.
Yeah.
How is
Slow,
your
long
practice?
inflations,
Do you do
correct?
long? Yes. I think that's a bubble there. That's okay. So there it is, the balloon is inflated. And if I can get a good flow in this vessel, that should do well for the patient, I'm sure.
Certainly will. Yeah, I mean,
I'll
you're,
just try and show you the radiography of the wound there.
yes.
Just unlock. There you can see that out here is the air within the gauze piece and the dressing which has been done for a deep wound there.
I see. Yes.
So if I can get a good flow there, I'm okay with that, yeah.
No, I think you're doing
And
a
then
nice
I will
job of
struggle to open up
revascularizing his
ATA
whole
just as
foot.
a... Yes. So we do follow angiosome concept. How is it with you, Manish?
Absolutely, Vimal. We are doing more and more of that. There's some nice new radiographic technologies coming out, both with Philips and Siemens, also to help with the angiosomal the angiosomal concept of revascularizing the zones that are required to heal wounds. And I think that's the absolute correct concept, because you cannot obviously fix everything in this particular below knee segment, but you need to fix what needs to be fixed
Right.
in order to get the wound healed.
Right. So this is what we're doing just now. And I'm waiting for we've just completed about a minute of dilatation.
Get a microphone.
What pressure have we got now? We've gone up to
All the
12
studies
atmosphere
show
pressure here.
us stunting in this area, long term, is not good.
Yes,
Prognosis
that's
is
correct.
not good.
Yes.
But it's just enough for healing the wounds.
That's correct.
For building collateral.
So what he's going to do, we don't know. What we're trying to do is eliminate having this patient have an amputation. So if we can revascularize the segment and heal the wound and prevent an amputation, that's the point.
You are right, you are right.
Okay, and so although we don't have what we have in the coronaries as really durable products, I think we're going to get there eventually at some point with below knee segments as well.
Unfortunately, drug-eluting balloon and drug-eluting stent in this area show in the studies bad results. So
We do have DCB data that is suggesting better results. We don't have a panacea for this, for sure.
We do have drug-coated balloons for this territory.
Yes.
However, cost is a major issue for us.
Yes.
And so therefore, where's the upper end of my wire balloon? There,
You can pull it.
little more.
Do you
So I'm
want,
going to just kind of pull the balloon out a little and open up the whole of the PTA territory. Okay.
So what is your method here in India, Vimal? You will treat this with balloon only and let it heal? You'll put a stent into this? If you're not going to DCB,
Okay, so my first approach in these kind of patients would have been via this and a drug-coated balloon.
Yes.
If it was a badly calcified lesion, I would have used a turbo hawk and probably done some atherectomy here
Mm-hmm.
and then drug-coated over it.
Yes.
Stents, very rarely, spot stenting is what I normally end up doing. And so far we've been using coronary stents, drug-coated coronary stents in patients who can afford it.
Okay.
So that's the way I look at it, yes.
Understood. No, I mean, this is a very difficult dilemma of what is cost-effective and what is effective, period. And it's still a
Absolutely.
field that is growing, I agree. We're still lacking data in
Yes.
this segment, below knee segment.
Yeah, so the challenges are here, you have multivessel disease, you have calcified disease, you have so many CTOs, long CTOs, and definitely the new technology has helped us to travel all these distance. And I think the anti-grade puncture also, or the retrograde puncture, is also another thing which is a good way to, do these procedures.
Yeah, absolutely. Yeah.
But I think long term we still have a lot to, kind of learn and understand.
What is the market?
How is the drug-coated? Yeah, sorry,
what-
Manish, you go ahead.
The critical limb space in India, is that a big problem, and how are you managing that?
Yes, we have a big workload of critical limb ischemia. You get patients coming to us at this stage.
Yeah.
And they are all Rutherford 4, 5, 6.
Mm-hmm.
And really challenging work. Patients keep on hanging. The general practitioners often don't know what to do for this. Some amount of amputation is attempted. Again, the amputation has not worked. That's the time you think of doing an angio or something.
Right.
And even if you look at the original papers, you will see that there is no mention whether the artery was ever palpated.
Right.
So right from there, we have a problem where, yeah, we can just do that a little bit there, yeah, just to. So we just have a 2.5 balloon. I'm not going to work too hard on it. This is the popliteal segment. I'm just kind of smoothing it out
Yeah.
to help me do the remaining part. I think we'll not keep it too long. This is just a pre-dilatation. Finally, I'll do a 4 mm dilatation for the popliteal. And I'm planning to deploy the bioresorbable scaffold, which we have it with Merrill just now.
Yes.
I am the principal investigator for the project, and we've already done with a total of about 6 procedures have been done so far. And
Yeah.
we are looking at doing about 30 cases to come to a conclusion where we stand as far as the scaffold is concerned.
Yes.
I can tell you the 2 patients that I've done very well.
So it's a very
And,
exciting new
so these are early
program.
experience.
You're really pioneering
Yes.
this really globally. Uh, no such
Yes.
program exists, and we congratulate you for your partnership with Merrill in bringing
Yes.
BRS to the below knee segment.
Right. So hoping for probably by the year end, we should have a significant number of patients and some 6 months early results with few cases should give us a good direction where we are heading.
That's fantastic.
Okay, why am I pulling out? Okay, let me just take an initial run and see what is the status down there. What I've ballooned it is okay, or I need to go in again. 1 minute. Just go up. We have to realize that this kind of cases, the time taken is much longer, contrast is much higher, radiation is much higher. You got to keep on going and doing it again and again. So in between segment, as you can see, is not opening up. I may have to go in again and balloon dilate that.
Yeah,
so
we see that.
probably we'll have to push the catheter again.
Probably that was not a bubble. That was the tight,
It's a tight lesion.
yeah, tight lesion.
Yeah, yeah, I'm holding. Chuta? Sister, chhod do. The separated. Again. Push. Separate hua hai. Tu push kar. Oh. I'm getting the same problem again. Extension ka is shit hai. Okay. I have another problem again. The same extension is giving way on this side also. This push and pull is really a problem for us.
Yeah, we go through
So
the
Manisha,
same
take
problems.
your point. Yes.
If there was a kink, probably you
Okay,
need to
so-
change the extension.
Let me see. The wire has stopped over there. Whether it let me go in, and if I can get the wire out. No? It's a
What-
long way in. Okay.
Was that
So-
Conquest Pro?
This is a Conquest Pro. You need a 300 centimeter wire there, always.
Yeah, absolutely.
So, okay. I think I need to go in again. Painful. Really painful here. But.
No,
this-
you're doing
this-
a beautiful
this is
job. These are
not
the same
helping.
challenges we all face. Careful with that distal wire.
So you do have 7
There's the
French
balloon here. Can you see the balloon here?
sheath. So you can put the
Oh.
balloon inside the sheath,
Okay.
distal tip,
And trap it.
trap it. Yeah.
Yeah. So Vimal, another thought is
Sorry?
you have a 7 French sheath. You could trap it
Right.
with just putting the standard trap technique that we use in the coronaries by putting a balloon alongside it and then inflating it.
Okay, I'm not getting that. Okay. So, okay, so you mean to say you come proximally, put a balloon there and hold it there?
Correct. Just put
Short balloon.
put a coronary balloon 3035. Load it into the guide, into the sheath, inflate it where you want in the sheath proximal, and then you
Distal.
can beyond where your device is, and then you can trap the wire.
Okay, so I'm going to start all over again. And what I would suggest, meantime, I'll just ask my other colleague. We just did a transplant renal plasty and stenting just about 2 days ago. And
Okay.
my colleague is here, Dr. Jigar. Yeah, so he will just show you that case from there.
Hi, we hear
So
you.
you can all hear me?
Yes.
Yeah. So myself, Dr. Jigar, I am doing a fellowship here in the Kokilaben Hospital under the Vimal sir. So I am presenting the case of 52-year-old male, which we did day before yesterday. This male presented with the recent rise in blood pressure. So pressure was around 200 systolic. Post-transplant, his baseline pressure was around 150 millimeter by Hg, with also raising serum creatinine since last 15 days. So this patient has a transplant just 2 months back on the 15th February. He has also multiple problems like diabetes, hypertension, ischemic heart disease. For that, he has undergone bypass surgery. So as the serum creatinine was rising and the blood pressure was high, so we advised for the color Doppler. So which color Doppler showing the, you can see there is a aliasing which suggests you a turbulence, which on the peak systolic velocity when we assess on the pulse Doppler, it was showing as a 506. So it's a very severe stenosis at the level of anastomosis. So we planned for the angiography, and based on that we are going to decide whether plasty plus stenting. So these are the images which we took from the right common iliac, which is showing end-to-end anastomosis between the internal iliac artery and the transplanted kidney, where you can see there is a severe stenosis just at the level of staples. So it suggests you of anastomotic severe stenosis. You can see also in the run. So first, to get a good support, put the stent, we put the wire, and to put the crossover sheath. So we pass the wire, over that we put the crossover sheath, we selectively cannulate the internal iliac artery, and then take the internal iliac arteries run. So which is showing severe stenosis at the level of anastomosis. So we pass the
Dr. Jigar,
so
can
we
you
pass
show that
the,
again? Yeah, show us the angio again.
microcatheter across the stenosis. This procedure we did over the roadmap, but unfortunately I am not able to show this on the video. So we pass the wire. There is a two division of for the upper pole and the lower pole. So upper pole has a long distance to put. So we select the upper pole artery. So over that we put the balloon and dilate with the 4 by 10 mm. So proximal recipient's artery was of around 5 mm, and the donor side artery, means renal artery, was around 4.5 mm. So we is planning to put the around 5.56 mm stenting. So we want to do a under dilation, means 4 mm dilation, pre-dilation, just before putting the balloon mounted stent. I want to show some problem we usually face because of the stent system is bulky. So when we try to pass the stent, there is a chances of change in the wire position so you need good support at least, because this is a bulky system. So you can see what happens when you try to push through the stenosis. So you can see change in the direction of the wire, and it from the upper pole went into the lower pole. So over that we put the stent and check the position of the stent, and then we ultimately inflated the stent. So this is the 6 by 12 mm Merrill's stent. So you can see we are inflated at the nominal pressure. So this is the post stenting run. So this is the pre-stenting severe stenosis at the anastomotic site, and this is the post stent placement. So you can see good flow across the stent. So on the next day when we assess blood pressure return to the baseline, 152 by 88 mmHg. On the Doppler assessment there is no turbulent flow and the normal peak velocity. So earlier you can see there is a turbulent flow with aliasing, so which not aliasing in the post stenting. And
So,
also
Dr.
which was
Jigar,
peak
Dr.
systolic
Jigar.
velocity was 506, which returned to the 90 systolic peak systolic velocity.
Can you hear
so
me?
there is a significant improvement on the next day only. Thank you.
Dr. Jigar, what stent did you put in? It was a 6.0 by what?
So उधर अपन बाहर थे.
All right, Vimal, we're back to you.
Yes, so I'm not really getting back into the segment. It is probably gone out somewhere. So I'm gonna work on it again
Yeah.
and try and get the PTA back.
Very well. Take your
So,
time. We understand, and we're going to be with you for another 5 minutes or so for the transmission.
Yes, yes. So let me just try and get a wire across again back into the PTA. This was a segment probably I had a tough time ballooning it also.
Yeah, there was a
and
lesion there that was not
difficulty
expanded.
in getting the wire across. Yeah. So probably at that point I have kind of penetrated it. No, this is probably going out somewhere. No. Can I have the road map? Let me just have a soft road map. तो उतना नीचे मत ले, slightly ऊपर ही ले. Give me up only. So I just have the, yeah. Just a prograde wire देना मेरे को. Okay. Okay, let me just shoot and then you can show me, yeah. तो रोड मैप दिया है. Okay. Yeah.
Yeah, so you keep going into that,
So I will try and reach up to the lower end.
yeah.
If this does not work, then I'll be ready with the retrograde approach
Yeah.
and find a new path from there, because this will have a tendency to go into the area where there has been a catheter passage and a slight amount of balloon dilatation, which I have already attempted.
But you were in there, you should go back there.
You should be able to get back, yeah.
You know what I feel, am I out already here? No. Okay, let me see whether that wire helps me go down further. I'm just keeping the loop going now. Probably here I'm not in. Otherwise that should have been a very straightforward passage. Okay, rather than a road map, I think I'll just look at my calcium and see if that calcium helps me track my catheter wire again.
Yeah, you're following the
Sorry,
calcium.
just keep it up. No, my contrast there is troubling me now. Let me just rotate the leg. Thoda payala firwa, bhau. Thoda firwa. No, I'm not getting really the course. Just make the oblique, thoda oblique karo. Making this oblique, the screen or the patient's leg, no, go in the other direction. I'm not really seeing the calcium in the posterior tibial. Yeah. Again.
I thought
Soft
this was
injection, just make it
peroneal
soft. I think otherwise we'll be
formed
going
posterior
out.
tibial. I thought this was the peroneal forming the posterior tibial.
That's what I thought too.
Yeah, no, this is a peroneal. As I said,
Yeah.
the peroneal continued as a posterior tibial here.
Yes, yes.
So there was a kind of a congenital anomaly here. Sister, give me the wire again. Good flow. So we have a good flow in the catheter. Definitely this is a proximal segment of the artery, and therefore, should we take a stiff wire only? Stiff wire. We'll
What I
still
mean
try
to-
with the stiff wire and see if I can get a re-entry
See if you
into
can
the
penetrate, yeah.
distal branch.
So if it's curved,
Yes.
we know it's curved. It's to form that posterior tibial.
Yeah. So these CTO wires, we have definitely a challenge. They can penetrate and go out. And let me tell you that once they go out, they can track along the soft tissue or a perivascular segment very easily, which will give you a false sense of security that you're nicely inside the vessel. See, now I'm looking, looks that I'm in there.
Yeah, that's kind of looks like the,
Okay.
the track it's taking. That's the vessel.
Yeah, I'll see my microcatheter goes down, and I want to make a contrast injection in the microcatheter there.
Yeah, be good confirmation.
Yeah, that'll. You need to confirm your re-entry again. I'm finding it difficult here. Let me just see if I can go back and then make a dye injection in the. So probably no, I may not be in. When you have such a problem here, then you're probably not in. Let me just check it up. I'm going to withdraw my wire
This is
and
glide,
see if the blood comes out in
glide
my
catheter?
catheter. That should be a good sign.
glide catheter, is it?
I don't know what catheter. you have.
Yeah, I've got a prograde terumo, yeah.
So the,
Prograde catheter, I have it. No,
so
this
the
is
profile of proglide catheter is bigger than the nanocross.
Yeah.
So that's why it's not crossing right now.
yes. And what happens is the wire is O14. and the catheter tip is 018.
Yeah, it's
So
not
there's a
enough
play
body.
between the two. Yeah, can I just make a dye injection and confirm there's a minimal flow in my catheter, which I'm not too happy though. No, we are out. As you can see, I'm still out.
Yeah,
I may have to take a retrograde puncture now.
I think you just get the wire
Back.
in, the BMW long exchange, then get
Yeah,
a
across.
longer balloon, longer inflation. So this is the area of perforation from the wire.
Yes.
Not from the balloon.
This
it's
is
the
where
wire.
I have perforated out. So let me just come up and see again if I can make a proximal injection. Because this segment I crossed it very well. So somewhere here, I think I've gone out.
Yeah, you've gone out through the collateral.
There the vessel is seen. Yep.
But it's
Just let me
easily
just try once
sealable.
again, otherwise I'll take a retrograde puncture.
Okay, we'll,
And that will
we'll,
take
we'll
time
stick with
for
you
me,
for
so
another
I
2
think I
minutes
won't
or
be able
so,
to
and then
show
we'll
you.
move on. But this has been a...
Sure. So let me just work on this and see if I can get it across.
Yes.
Would you apply cuff pressure in the this area?
Yes, in this territory. Yeah, where there is a rupture, I'm going to apply that. See that my wire is going
Yeah.
out there.
That's the rupture area.
So I'm trying, sister, give me a talker there. Yeah, now probably this is a passage that I've got
Yes.
now. So here we are.
You want to
We
give us a
finally
summary?
went with an ultrasound
Yeah.
and we punctured the posterior tibial artery near the ankle.
Yes.
And from there we got a retrograde puncture, and we had a little difficulty in going past the CTO
Yes.
in the mid posterior tibial artery.
Not,
And
not unexpected.
finally we did manage with the stiff and the soft wire combination, one after the other. And from retrograde approach we could cross the lesion. And finally we could enter into the diagnostic catheter, which we had placed it in the popliteal artery.
Okay.
And then we went ahead and then balloon dilated it. And now we are, we will show you those pictures where we have done the, can we go roll this down completely? We will show you what we have achieved so far.
Okay.
So there we are, let me see the picture. Just go up. Where's the puncture? Yeah. Okay, there you are.
So
That
thi-
we
so
got
thi-
a 4 French micro puncture set from Cook.
Yep.
So we punctured the popliteal, the posterior tibial artery near the ankle, and you can now see my catheter, which was a pro-grade catheter. We managed to go up into the posterior tibial artery.
Okay.
Next. There we see that we are getting stuck here again.
Yeah. That's where your CTO segment is. Yep.
Next. That's right. So we did a roadmap from up, down, everywhere. Next. We are from the proximal end. We now know very short distance which was not going in.
Yeah.
Next. Finally, we did, we felt we have gone in, but it was again, I was not sure. It looked as if it was outside. As the wire was not progressing ahead very easily, smoothly. There we were getting stuck. So we were probably in the subendomal plane. Then we finally got a catheter with a microcatheter and a Terumo microcatheter wire. We did cross it over it. And there you can see both the catheters looking at each other. Next. And we were trying to get back into the diagnostic catheter.
Yeah.
Now we got both these things looking at each other, and this was a Filter FC wire. No, it is going by the side. Next. Finally, we did manage to get it in,
Beautiful.
and we
And then you
kind of got it
externalized.
there, and now you can see we've got the balloon.
Okay,
Yeah, we
so-
externalized the wire on both the ends, which is there on the other video, but that is not showing just now.
It's okay.
And now we've got a balloon there.
And you're ready to dilate.
Yes, we dilated at various segments.
And were you able
There
to
you can see
expand
the
that area?
dilatation
There's
there.
that one area that's in the middle that's not expanding.
Yes, yes. We did manage to get that dilatation also. There it is.
Yes.
Next. And we again kept a prolonged high pressure dilatation. Next. So here we can see the diagnostic. We were not too happy at the tibioperoneal trunk, just
Right.
beyond the origin of the anterior tibial. Looks
Right.
irregular.
Quite dissected, yeah.
So we redilated it over there, yes. Lower end you can now see it's very good. The narrowed segment is where my sheath is in the foot.
Correct. Yes, we see that. Uh-huh.
I will remove it finally, yes.
So this is a
Next.
very elegant antegrade, retrograde, classic long CTO segment for critical limb ischemia, and we commend you for your bravery. How did you manage the perforation, Vimal?
We've just left it. We kept the balloon there for a long time, and we kept an external pressure.
Okay. And what do you keep your
This
ACTs
is the segment
with
that we are
heparin?
looking at. We've kept it over 200 at present.
Okay. And your plan for the popliteal is what?
Next. We will be putting the bioresorbable scaffold, the Credence BTK.
Wonderful. So you're going to do
Yeah.
some vessel
So here
prep.
we are, we have gone past the, yeah. So we'll keep a balloon here for a time being, till the time we remove the sheath from the ankle.
Yeah. Very
And,
nice.
So that will act as a tamponade, yes, and that is what we're planning to do. So this was the last picture that we have? Yeah, these are the last pictures that I have. We still got some work to finish. I don't think so I'm gonna walk around on the anterior tibial though,
Yeah, I think this is enough for today.
because I don't want more contrast. Yes, and contrast would be too much, yes.
Well, we want to thank you for a wonderful demonstration of a complex case for critical limb, both, as I said, using antegrade
Yes.
and retrograde techniques. We want to thank your team on Saturday morning for being there to do this with us. Congratulations.
Thank you very much, all of you.
See you soon, and good
hope
luck with the
you
rest of
all
the
start
procedure.
doing some work there.
Yes, okay.
Thank you very much.
My
Thanks,
pleasure.
Manish.
Thank you.
Thanks a lot.
Bye-bye.
Thank you. Bye-bye. Bye.